Top Med Talk.
Hello and welcome to Top Med Talk Down Under. I'm Kate Leslie and I'm here with my co-host Andy Cumpstey at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine annual scientific meeting, and we're in Brisbane in Australia. This is the biggest annual anaesthesia and pain medicine conference in the region with around 2,000 delegates. And we're in the booth in the healthcare industry reception now. And Andy, I think there's a great buzz going on with people catching up and looking at the products and enjoying a coffee.
There's a fantastic buzz both in this room but also outside. There's lots of people arriving with these black gowns with gold edges on. Do you want to tell us what that's all about for later?
Tonight is the college graduation ceremony. Fantastic. And we have a record number of people, Hance and Vivanne, so that you're going to have to sit through more than 300 people.
Wow.
Are backed up from the pandemic to get to receive a handshake from the president and their diploma of fellowship of the college or of the Faculty of Pain Medicine.
Yeah, and you've obviously been to this before. You're going to put all your gongs and medals on and get dressed up, aren't you? It's quite a big event, I think.
Yes, I've been to every one of these since 1994.
Wow.
Yes.
So tonight's a big night for all these people who work really hard to get their FANTA qualifications. So.
Yeah, I really enjoy it. It's a great event.
Yeah, it's great to have that as part of this meeting, isn't it? So,
totally.
Yeah.
Will we be getting some shots of coffee?
Absolutely, yeah. We're right next to a big coffee booth, aren't we? So you'll hear lots of coffee as well going on behind us. We've got some fantastic guests sitting with us today. So it's great to welcome Vivanne and Hance with us here. Why don't you start, Vivanne? Tell us a bit about yourself and what you've just given us a fantastic opening plenary session about.
Yeah, thank you so much. Thanks for having me. So my name is Vivanne Tawfik. I'm an associate professor at Stanford University in Palo Alto, California, in the United States. I spend my time split between clinical work and research. I see patients with complex chronic pain in the clinic 1 day a week, and the rest of the time I'm doing basic science, what I call clinically informed basic science, in a research lab. I'm trying to understand the mechanisms of transition from acute to chronic pain with a focus on glial cells.
And what do you mean by clinically informed basic science? And I've got to ask, that's a fantastic term.
Yeah, I think I coined it. So the concept really is that seeing patients gives me an edge to understand what their issues are and what types of mechanisms we need to seek out on the basic science side that we can't necessarily answer through human clinical trials. So one quick example is that I spoke about this yesterday to FPM, but we use a drug called hydroxychloroquine to treat some types of autoimmune mediated pain. And we really don't know the mechanism of its action in humans. And so we have an animal model of complex regional pain syndrome, and we gave hydroxychloroquine to the mice, and we were able to see that actually it modulated microglial cells in the spinal cord. And so that sort of idea of taking what we're seeing in the clinic, bringing it to the lab, and then using that to then forward translate more effectively.
Fantastic. And you've just given us a fantastic opening plenary session, an hour ago now, as part of the opening of big day of the conference?
Yeah, so that was a different focus, a little more towards like clinical work. So really I was trying to present some clinical pearls for anaesthetists in the perioperative period to improve their care of patients with chronic pain.
Do you want to summarize some of those key points for our listeners back at home that couldn't make your excellent session?
Yeah, sure. So I was trying to highlight some of the controversies, but also some of the important things to think about when taking care of patients who come with a history of chronic pain, because that is, we know, a factor that puts them at higher risk for chronic post-surgical pain or persistent post-surgical pain. So things like perioperative gabapentinoids, even tricyclic antidepressants, they're controversial, but at the same time may have potential benefit. So being able to balance risk and benefit when we're thinking about our anesthetic plan for these patients, and then thinking a bit more broadly about infusions we can run, such as ketamine, which I think we'll talk about in a little while, or IV lidocaine. And then really kind of maybe out there for a lot of people, but going back to drugs like methadone, which are, is an opioid, very long acting, but maybe actually pretty effective for perioperative pain control.
Hance, over to you. Can you tell us a bit about yourself and your work?
Sure. I'm a staff anesthesiologist at Toronto General. I'm an associate professor at the University of Toronto. I run a pain research unit. Like Vivanne, I do a couple days a week clinically, and the rest of it's typically research related as well. All things opioid crisis, cannabinoids, transitional pain program/service that we created about 2014. It's our 10-year anniversary this year of that program. So
what are you going to talk about at the meeting to the anaesthetic group? You've already talked to the Faculty of Pain Medicine, I think, at their symposium.
So I think we're sitting here in about an hour. We're going to be talking about cannabinoids and cannabis-based medicine in Canada and some of the things we're dealing with since we've completely recreationally legalized the drug in 2018. I'll also be talking about our transitional pain service and some of our pain program opioid policies, things of that nature in Canada. Actually, I'll give us a plug. Vivi and I are doing a big symposium in a couple of weeks in Seattle, looking at policy and opioids and all these things in North America.
It sounds fantastic. I must say, in Australia, we have a lot of recreational use of cannabis, and some of the heavy users of cannabis can be a really big problem post-operatively. Can you talk about your experience at all with that in Canada?
Oh, absolutely. So we were, this was an issue for us in 2018, around that time. And so myself and Kareem Latta, also one of my colleagues, put together a Delphi looking at perioperative considerations for individuals using cannabis and cannabinoid-based medicines. And we were then followed up with we created a guideline, and then the Association for the ASRA folks, so the American Society for Regional Anesthesia and Pain Medicine, then put together another group, which I was part of. They were significantly more comprehensive in terms of cannabis guidelines for individuals coming for surgery and using cannabis. And so they have a really cool poster that you can talk about, what if you're using cannabis, how much you're using. If you're acutely intoxicated, perhaps maybe we don't proceed with putting you to sleep. And there's no doubt that there is an association with, increased nausea, vomiting, agitation, pain in the perioperative setting if you have been using cannabis. And in particular, if you're now devoid of it, if you've been asleep for quite some time and maybe in a slight withdrawal state, perhaps.
Yeah, and cannabis use is also legal in some respects in California, Vivanne.
Yeah, so there is a lot of cannabis use in California. We do see, I guess, similarly with sort of, it's not legalized, but it's decriminalized in a lot of the United States. And I think, at least from the pain management side, many of my patients use cannabis. I think it's still a little bit of a no data zone in terms of, how useful it is. I mean, some patients sort of swear by it, but at the same time continue to have really high impact chronic pain. I think some of the work like what Hance is doing is really helpful to give us a little bit of guidance on what to do with these patients. And then just as again, clinically informed basic science, we have some work that we're doing trying to improve on cannabinoids and really try to come up with cannabinoids that are binding to cannabinoid receptors, but not activating them in the same way that THC does, so that we can get some of the benefits without the side effects. THC is the active ingredient in cannabis, and THC, as well as some of the other ingredients like CBD or cannabidiol, are thought to be some of the active ingredients that maybe help with pain, but also are why people continue to use these products. So trying to improve on those derivatives in a way that we can make them, useful with less side effects.
So if I'm about to anesthetize one of these patients who's possibly in a slight state of withdrawal or is normally taking cannabis at home, what sort of agents would be the best for me to be using to manage their pain then?
It depends on your country, obviously, because what I would say is, in Canada, we have nabilone. In the US, they have dronabinol. And so those are THC agonists. And the real question is, what has the patient been using? And we all gravitate around, all cannabis is weed, et cetera. But, some patients are actually using medically authorized CBD, medically authorized 1-to-1 ratios of these things. And, starting to ask your patients, what are they using? Starting to figure out, how often they use. Are they just weekend warriors that it's not a big deal that they can stop before an operation? But it's someone that's using it medically authorized. That's someone that there's no reason they can't continue using their products. And in Canada, we have policies now in place where they can bring it into the hospital and they'll have it dispensed just like their opioids on a routine basis.
Wow, we do not do that in the United States.
Well, I was just about to say.
Shocking.
Yeah, we do not do that in the UK either. And I don't know
we don't do that in Australia. But some of our patients nip out the front of the hospital to get their cannabis dose while they're inpatients, which is something that we really need to also consider.
So remember, it's completely legal now, right? And it is a recreationally legal product, and someone using this with a medical authorization has full access to use it, and it's part of their healthcare.
Wow.
Yes.
Right?
Yeah, that's a big difference between decriminalization, which is what we really have, legalization.
Yeah, so let's move on to some other interesting drugs that are used in the community. Ketamine and psilocybin and those sorts of things. We've read about basic science and also initial clinical trials using those in pain, but also in depression. Have you got anything from your research that informs this discussion, Vivanne?
Yeah, so I'll start with ketamine because I think it's the more sort of commonly seen medication right now. In the U.S. and maybe in California in particular, it's come to the point where you can go to any physician and get a ketamine infusion and pay cash for it.
Really?
Yeah.
Wow.
Yeah. It's like any boardwalk in California. So it's really gotten to the point where, its use in depression has become very, very widespread. What we haven't seen is that kind of movement for pain. There is data to support the use of ketamine for chronic pain, and we have patients who come into the hospital for multi-day ketamine infusions at our center, but it's not always covered by insurance, making it pretty complicated.
Yeah, I was going to ask you about that because you mentioned that in your talk this morning, which that's definitely not something that we do routinely in Southampton in the UK, for example. So you touched on some of the data in the talk, but is that a very common thing that many of your patients are getting, or is it in certain cases? Are you choosing it for certain people?
Yeah, so there's sort of two different groups, I would say. So there's the perioperative ketamine, so running it intraoperatively is very common.
Yeah.
And then running it in the postoperative period, I'd say, is quite common, especially for patients with pre-existing chronic pain.
Right.
Separate from that, we have patients with chronic pain who we admit to our service at the hospital, and we admit them just for treatment of their chronic pain with ketamine. And that's sort of a different group. And that's harder to get covered because it's not widely recognized that ketamine is beneficial for chronic pain and often gets considered to be investigational. For the treatment of some conditions, such as complex regional pain syndrome, which is a condition I treat almost entirely, that condition, it does have pretty good data. I mean, as good as it gets, I would say, for, these types of rare disorders. It occasionally will get covered for that. So we sort of have two groups who could have benefit from ketamine, either in the perioperative period or for chronic pain. And then this separate group of sort of extremely extensive cash pay, few hour ketamine infusions in the community.
I have a question for you. We use a lot of ketamine in Australia, but there are some patients who don't like it. They've got it in the ambulance, or they might have had it for pain or used it recreationally, and they get disturbing psychological effects. Do you know how we could get a product that had the pain benefits without those disturbing psychological problems?
I mean, I don't think there's good options right now. I think it really depends on what else the patient's getting. So, for example, when we do the infusions in just our chronic pain population, we're often using benzodiazepines to offset some of the side effects you mentioned, especially the psychiatric side effects. Clonidine is often used also to offset some of that. In the perioperative period, a lot of times they're getting propofol or an inhalational anesthetic, so they don't necessarily get that. Getting ketamine, like in an ambulance, if it's not in combination with some sort of sedative, and especially at the doses that are sometimes given, I think, in these like EMS type situations, I think it's really hard to mitigate some of those risks.
So there's no molecular mechanism that you can think of where the pain and the psychiatric side effects could be divorced, that they're working the same way through the NMDA receptor?
At this point, I don't know. I don't know that there is. As far as I know, no one has looked at that, but I don't know. Maybe you know about that.
In Canada, we were, again, a little bit more fortunate because the government will cover ketamine from a chronic pain perspective, 6 infusions a year. So every 8 weeks, you can have your infusion. If you buy it effective, you will have to have failed first-line treatment, so the gabapentinoids and the SNRIs, these other drugs. And just to round back to your question, there are patients that I know are returning for the mood effect and not the pain effect.
Is that right?
And so, I think there probably is a way. Obviously, you've got some type of serotonin bump happening in the brain, even though we're looking at an MDA mechanism. So there's other areas of this molecule that are being affected.
And what sort of doses are you giving these patients then in those kind of repeat infusions?
Well, so actually it was, I was at Vivanne's talk yesterday, and she said, the ones who seem to really respond well are the ones who respond at those lower doses.
Right.
I unfortunately have these folks that they really like these bigger doses, and I think it's for that dissociative effect, and some people really like that. And so, to your point, Kate, when someone has adverse childhood events, in particular, I'm very careful with women if they've had a sexual traumatic, event in their life, because they're the ones I ask in advance, what are your traumas? The one issue you could have is a really significant trigger of those previous traumas before we head down this road, and I'll start a little lower. So it was interesting to see that the folks that respond lower in Vivanne's work are the ones who do well.
So coming back to again your talk from this morning, Vivanne, so you mentioned about the ketamine infusions intraoperatively and postoperatively. Is there any ongoing work in that sort of area, looking at what might be the next best thing with ketamine or the next sort of...
I mean, specifically next best to ketamine, I think, people are using things like lidocaine, I mentioned this morning. So IV, local anesthetic has been a really popular option for us. We use it, I'd say, a lot, especially in the postoperative period for patients who aren't eligible for regional anesthetic or, it's contraindicated or whatever it is. So we're using a lot of IV lidocaine. I don't know if you want to talk about like the really kind of out there thing when you asked about psilocybin at the beginning. But there is sort of, I think, a lot of momentum towards finding, the next panacea for the treatment of pain and all that ails us. In Silicon Valley, where I live, there's a lot of money being thrown at research on psilocybin. I think it's a bit, I'm very tentative in my opinion on it. We have done one animal study looking at the use of psilocybin across multiple different pain models, and we've seen absolutely nothing. No effect on any of our pain outcomes in mice at all.
Right.
I mean, they're the most negative data I've ever looked at in my life. So I'm really hesitant to suddenly embrace psilocybin as like, our best new analgesic. And I think it's really concerning that how quickly people are sort of moving to adopt it before we have any data from any, more than like one study I think there is out there.
Yeah, I think we interviewers and the community in general love talking about these wild drugs, but it probably in pain medicine has a lot more to teach anesthesiology about how to talk to patients, particularly preoperatively, about their issues. And I was interested that you raised that you talk with patients about their traumas. And I do orthopedic trauma, so they've had a traumatic event. But I've been taught to talk just a little bit more about their social context, the catastrophizing thing. So for the anaesthetists and pain medicine, perioperative physicians who are listening, how do you talk to open a conversation about sexual and physical abuse with a patient while you're preparing them for surgery, or is that a good idea?
It's always a good idea. You want to know as much information about your patient, and you actually want to be direct. And so, as you would ask about your heart meds, and you ask about your blood pressure, and you ask about the Resperol, your social context. And let's be clear, 30% of all people that have surgery consider surgery a traumatic event in their life. And so with that data, and you talked about catastrophizing and talked about anxiety in the orthopedic literature, one of our most cited papers was a paper in Pain in 2015 looking at the trajectories of folks post-knee arthroplasty. And you could pick out the individuals that were not going to be doing well at a year simply by asking them about their anxiety, preoperative anxiety and catastrophizing. And so these are concepts that need to start to percolate to the top of preoperative assessments. If we can already identify folks that are going to struggle, we should be intervening before surgery. In the orthopedic conferences, they're talking about not even operating on individuals with high anxiety and high catastrophizing because they know they're not going to do as well. And so, knowledge is power. And then when you have the information, what's the number one issue that folks that are A-type, that have that light control, when they come into a hospital environment, they have zero control. And so the more education, the more preoperative information people have, the better these perioperative journeys will be. And it's the whole concept of the transitional pain service, the perioperative home that I know the Americans like to talk about. We are more than just putting people to sleep and waking them up. And it starts before, and it continues well beyond discharge. And we should be the ones owning this space, period.
Totally. I mean, I think about that with my ortho trauma patients, because some of the people who slipped and fell at home or whatever were actually pushed. Right. There's a hidden burden of domestic violence in that particular population.
Domestic violence, and another area is just substance use, alcoholism. We know smoking and terrible outcomes. Opioid use disorder. All of these things. There's news that perioperative SIGs being built around all of these issues because we've kind of just pushed them aside for many years and apples aren't always apples, right? There's something else happening in the background sometimes.
Yeah.
Well, I'd love to hear more about this, but I think we're running slightly out of time. But for everybody else at home, thank you very much for listening to us on Top Med Talk Down Under. You can find links to each of our episodes in the daily conference newsletters, on our Top Med Talk app, on our YouTube channel, on X, or on our Facebook accounts. Thanks for our fantastic guests, and we look forward to you joining our conversations next time.
Top Med Talk, Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.